Hello, everybody, and welcome to MacroPro and Friends. We have SRTK as our guest, our special guest this week, and we have Melissa Downing, who's co-hosting with me. Melissa, how are you doing?
I'm doing well, Diane. Thank you so much for having us again.
Oh, well, I'm really glad that you guys can do this special Encore presentation. It was so well received before. So we want to just tell you a little bit of housekeeping before Melissa tells us about our speakers. And so I just want to tell you about your CEU credits. So first of all, you will be receiving an email that says your certificate has arrived. It's got a little blue button. Please make sure you click onto that. You'll get it within the next 24 hours and your certificate will appear. Secondly, if you would like to download today's handout materials, there is a spot for handouts. You just click onto that, download it, and you can follow along with us today. And then lastly, if you have any questions, there is a chat box. So feel free to ask any questions inside the chat box. Melissa and I will be watching that and we'll be happy to ask our experts. Now, I do want to let you know this is a jam-packed presentation, so we may not get to all of the questions, but I will share the questions with our experts afterwards. So if they get the opportunity to reply to you, they certainly will. So Melissa, tell us about our speakers today and what they're going to be speaking about.
Thank you, Diane. Well, our legal experts today on COVID-19 claims, how do you respond, is Joanne Thomas. She is our shareholder and chief executive officer, and Joanne has the Inland Empire and San Diego venues. Timothy Kinsey is our CFO and shareholder of our Orange County office. And Dr. Dawes has been the medical director for Safeway Bonds for the past 4 years, and he is also the medical director for Employee Health Services at UCSF Benioff Children's Hospital in Oakland, California. And then just a quick highlight of the offices that we have coverage throughout the state, so we're here for your litigated claims. And I will turn it over to Joanne Thomas.
Well, thank you all for being here today.
Thank you. This is awesome. All right, let's get into it. First, we're going to go over the statutes. And then we're going to get into some best practices and strategies and hear all of the wonderful good things Dr. Dawes has to teach us today. All right, we're going to start with Labor Code Section 3212.86. This is the codification of Gavin Newsom's executive order. This statute only applies between March 19th and July 5th, and it applies to any worker who tested positive or was diagnosed with COVID-19 within 14 days of performing work at the employee's place of employment at the direction of the employer. This is very important. Again, it's testing positive within 14 days of work. That's key information. This statute sunsets on January 1st, 2023, and the positive test must occur or the diagnosis within 14 days of labor services. Okay, and the services must be performed at the direction of the employer at the employee's place of employment. For this statute, place of employment does not include the employee's residence. And key information, the date of injury is the last day the employee performed services at the place of employment. So it's not the date of the positive test, unless it's exactly the same day. It's the date that they performed services. Okay, so going back over, the employee must test positive or be diagnosed with COVID-19. If it's only a diagnosis, it must be by a licensed physician and surgeon holding an MD or a DO degree or state licensed physician assistant or nurse practitioner supervised by a physician and surgeon within their authorized scope of practice. And then the diagnosis must be confirmed by a COVID-19 serologic test within 13 days of the diagnosis. Key information, it needs to be a serologic test. And if the claim is not rejected within 30 days, it is compensable unless rebutted by evidence discovered outside of the 30-day period.
So, Doctor, I have a question for you. As we'll see later in some of the statutes, the testing is referred to PCR testing. In 3212.86, as Joanne indicated, it's a serologic test. Can you kind of give us an idea as to the difference between those tests?
Sure. The polymerase chain reaction test looks for active virus present in the individual at the time that the test was done. And so these tests are more readily available at this time, whereas, at the time of this statute, they weren't as readily available. And so we had to rely on a test which would tell us whether the person had likely been infected within the recent past. And so a serologic test looks for the presence of antibodies against COVID-19 or the SARS-CoV-2 virus. And so that's why there's a difference between the two.
So potentially someone with a positive serologic test may not necessarily have COVID-19, but could have already had COVID-19.
That is correct. It does not test for active infection. It tests for a history of infection, and the person may have active disease or may not. But if it's 30 days afterwards, it's presumably they hopefully don't have active disease present.
All right, so let's go over TD and death benefits under Labor Code 3212.86. Before any liability arises for TD benefits, the employee must exhaust available COVID-19 specific benefits for sick leave. And then TD and Labor Code Section 4850 benefits apply. And there's no waiting period for TD benefits under this statute. And if the injury results in death, no death benefits are owed if there are no dependents. If there are dependents, death benefits are owed. All right, so let's talk about TD certification. If the employee has tested positive or diagnosed with COVID-19 on or after May 6, 2020, the employee shall be certified for temporary disability within the first 15 days after the diagnosis, and then shall be diagnosed and recertified for temporary disability every 15 days thereafter for the first 45 days following the diagnosis. And if the employee tested positive or was diagnosed for COVID-19 before May 6, 2020, then they have to obtain certification no later than May 21st, 2020, documented in the period that they were temporarily disabled and unable to work, and shall be recertified for temporary disability every 15 days thereafter for the first 45 days following the diagnosis.
Good morning, everyone. As Joanne was discussing, 3212.86, that was a codification of the executive order that we had previously seen in effect earlier the year. 3212.87 is one of the very first new legislative statutes to address COVID. This statute's effective as of July 6, 2020, and it sunsets on January 1st, 2023. It's a very specific statute, and it applies for firefighters, fire and rescue coordinators, chief officers, healthcare workers in contact with COVID-19 patients at a health facility, and in-home support services, workers providing services outside of their own homes. If it's one of those individuals that presents with COVID, potentially there's a presumption of compensability that the COVID is industrially related. What we're looking for is that the employee is tested positive for COVID-19 within 14 days after the day that the employee performed labor or services at the employee's place of employment at the employer's direction. Unlike the 3212.86 codification of the executive order, this particular diagnosis of COVID-19 cannot be made merely by diagnosis. In other words, the presumption doesn't kick in as it did under the 3212.86 based upon a diagnosis. So it's more stringent. And in fact, it's more stringent because a serologic test doesn't work either. Okay, the test has to be a PCR test that's been approved by the US FDA. So we need both of those things in order to have this presumption kick in. Okay, the date of injury is the last date that the employee performed work at the employer's place of employment, okay, which is not the employee's home, at the employer's direction prior to the test. Any claim filed by any of these individuals that is not rejected within 30 days is compensable unless it's rebutted by evidence discovered outside of that 30-day period. We're all very used to the 5402 90-day time frame. Obviously, this is drastically cut down. We've got 30 days to deny a claim that's deemed or that's filed under 3212.87. Okay, so we got to keep that in mind. That time frame is extremely short. And for healthcare workers The presumption doesn't apply if the employer can show that the employee didn't have contact with the facility patient within the last 14 days prior to the COVID-19 test. So that makes sense. TD and death benefits under 3212.87 are ironically almost identical to 3212.86. Actually, they are identical. Okay. TD and Labor Code Section 4850 benefits do not commence until COVID-19 specific time is exhausted. That could be COVID-19 specific time created by statute. It could be COVID-19 specific time created by union agreement, or just COVID-19 specific time created by any employer to be used specifically for individuals with COVID-19. Once that time exhausts, there is no waiting period for TTD. We have to pick up instantly. And if the injury results in death, there are no death benefits that are due and owing if there are no dependents.
Doctor, I have two questions for you before we move on. First is, can you help us with a framework on what we could look for to provide early identification of cases that are likely to be mild COVID cases with easy recovery and little to no PD, intermediate cases that might pose longer recovery and more medical treatment and expenses, and then those high exposure cases? And then the second question, I'll just let you ponder it now, is tell us what is required for COVID-19 to appear on a death certificate, because I personally am having some experience where I'm seeing it as maybe a contributing factor, but not the cause of death. And so are there any standards for when COVID-19 must be placed on a death certificate?
So I'll start with that question first concerning the death certificate, if that's okay. And according to the CDC, if the COVID is the direct cause of death, it should be listed as the primary. And then there are supporting or other contributing diagnoses such as, lung problems or heart problems, which could also contribute it. However, this is controversial in terms of it's a decision making, it's a physician making that decision without necessarily reviewing all the medical records, etc. So I think if there are a number of contributing conditions listed, even though COVID is listed as the primary, it's worth pursuing and looking at to see if you're responsible for the entirety of it, or whether there were significant contributing events to that death certificate. So I think that's one of the factors. As physicians, we try to be as specific as possible, but some of these are still open to interpretation, and I think it's important to review that. With respect to, looking at who's going to be sick and who's not going to be sick, and who do we need to be concerned about for having residual symptoms in the future, I think the biggest issue is most of the people that we are probably going to observe are going to, meet the quarantine requirements, not necessarily be very symptomatic, and will continue on with life as before. Those other individuals that have a pre-existing lung problem or heart problem, I think that they are the ones that are going to have clinically meaningful sickness after they recover, depending on how severe the infection was, whether they were hospitalized or not hospitalized. And then, of course, you have the very sick people that were, basically what I would call the working wounded to begin with. And this is something that's just going to set them off, whereas where they were borderline oxygen dependent, now they're oxygen dependent. And it's unlikely that they're going to recover to no longer require oxygen. So I think those are that's the third group of people that we need to be concerned about. And then the other issue too is that this illness is just like any other work-related injury that we see. There are potential risk factors for delayed recovery that are not necessarily related to the illness itself, but more about what the individual's coping skills and how they handle the injury and the illness and its impact on them. And those are some of the things that we typically look at from a delayed recovery standpoint. And people bring some anxiety or poor coping skills to the equation that can also contribute to the length of or duration of disability, just like any other type of work-related injury.
Oh, interesting.
Does that
Okay,
answer?
that's great. Yeah. So what I got out of it, the key thing that came to my mind when you said that is look at the oxygen dependence during the COVID as a potential indicator of a long-term higher risk for a bigger case, right?
I think that's a great single thing to look at. Oxygen dependence.
Okay.
Yeah, and then yeah.
Perfect. That's great information. All right. So now we're going to go over, something else, Doctor?
No.
Okay. We're going to go over the outbreak statute now. So we have 3212.88. We have some really good information for how to calculate the outbreak that's going to be coming at this section. So for the outbreak statute to apply, the employer must have more than 5 employees. And this statute applies to all employees except those covered by 3212.87. And where there's an outbreak at the place of employment, of course, we have outbreak in quotes because there's going to be a definition of that coming. This statute, 3212.88, applies on or after July 6th. And this is, of course, the time frame when the executive order no longer applies. And this statute sunsets on January 1st, 2023. Definition of the specific place of employment means the building, store, facility, or agricultural field where the employee performs the work at the employer's direction and does not include the employee's residence unless the employee provides home health care services to another individual at the employee's home. What I want to say here is just keep in mind that if you've got multiple buildings on a job site and they share a parking garage elevator or a lunchroom or a restroom facility, you got to be looking at whether that constitutes a place of employment rather than multiple places of employment. So keep that in mind. And the date of injury is the last date the employee performed services at the employee's specific place of employment. So again, it's the last date of services, not the date of the test. And if the claim is not rejected within 45 days, it's compensable unless rebutted by evidence discovered outside of the 45-day period. And okay, so an outbreak exists within 14 calendar days. One of the following occurs at a specific place of employment. So let's just look at when there's less than 100 employees at a particular place of employment, there needs to be 4 employees that test positive for COVID-19. If you have more than 100 employees at a specific place of employment, it's 4% of the employees who report to that specific place of employment test positive for COVID-19. Now, the positive COVID-19 test within 14 days after the day the employee performed labor services at the employer's place of employment at the employer's direction through a PCR test or other comparable FDA approved test which shows the presence of RNA. And this does not include a serologic test, very key information, which shows antibodies and not an active virus.
Joanne, can we talk about that 14 days briefly?
Yes, please.
So the statute, because I know everybody just loves to go through these statutes on Friday and Saturday nights. The statute basically straight up discusses that 14 days. And what it says is that a claim is not part of an outbreak if it occurs during a continuous 14-day period where the requisite number of positive tests under paragraph 4 of subdivision M, which Joanne has already discussed, have not been met. For the purposes of applying the presumption to this section, the claims administrator shall continually evaluate each claim to determine whether the requisite number of positive tests have occurred during the surrounding 14-day periods. So long story short is in determining whether an individual actually falls under this presumption, we have to do a little math. Fortunately for me, it's not complicated because it only involves 14 plus or 14 minus. I don't even have to get out my iPhone for that. So what we need to do is we need to remember that that 14 days is either side of that claim, okay, of that last day worked. It could be that when Bob files his claim, he's the one that pushes it over the presumptive number of cases, right? Bob may break the proverbial COVID camel's back with his claim. So we're continuously having to evaluate each claim when it is filed to determine if within 14 days prior or 14 days subsequent to that last day, whether or not the requisite number of individual positive tests have been met. So something to keep in mind.
Right. So each person needs a different analysis, right? So theoretically, you could have 3 days apart from the last date they worked, and one applies to the presumption and one doesn't.
Right.
Okay. So that's really good information. Great.
So how do we come to those numbers? Well, there's some very specific reporting requirements under 3212.88. Employers must report some information to claims administrators within 3 business days. And that information is that an employee tested positive. Yeah. The employer cannot report any personally identifiable information along with that indication that an employee tested positive, unless the employee is also filing a workers' comp claim. Then we can provide that information. And I know there have been some challenges. I know that most of the TPAs now have already gotten over this hurdle. They have their gateways and portals to reporting this, where we're not trying to tie, where there's no way to tie that individual back to a name, to a social security number, to an employee number, date of birth, any of those things. Okay? We have to report the date that the employee tested positive, which is the date that the specimen was collected for testing, not the date they found out, but the date the specimen was collected. The specific address or addresses of each place where the person worked during the 14 days preceding the positive test, and the highest number of employees who reported to work at each specific place of employment in the 45-day period preceding the last day that the employee who tested positive worked at the same location. That's how we're getting those numbers to determine whether or not the individual within that 14-day time frame falls within that presumption. This is being self-regulated. However, as you can see, the state is quite serious about this. The penalty is up to $10,000 for failing to submit this information, or intentionally submitting false information or misleading information. So, yeah. TD and death benefits under 3212.88, without going over this again, are identical to 3212.86 and 3212.87.
All right, rebutting the presumption. Key information. The presumption is rebuttable and may be controverted, which is a word coming directly from the statute. We don't know precisely if a judge will consider rebutted, controverted, or vice versa. But the point is whether it's disputed by other evidence, okay? And this will be likely factual evidence, medical records. That's why getting these medical records are so key, as many as you can get. And then the employer for 3212.86, which covers, as we've discussed, all workers between March 19th, 2020 and July 5th, 2020, and Labor Code Section 3212.87, which are the firefighters, police officers, and healthcare workers. There's 30 days, as Tim mentioned earlier, which is a very short time frame. So we want to be on top of it from day one on these cases. For 3212.88, which is the outbreak statute we just talked about, there's 45 days to deny with controverted or rebuttable evidence. If the claim is not timely denied, of course, there's a presumption of compensability unless the rebuttals come in these specified timeframes.
So, as Joanne indicated, we as attorneys can do lots of this. We can get into that and deal with that factual issues in the case. As she said, we need to get those records and go through those records. However, we only play doctors in court. We are not doctors. So fortunately, however, we have with us Dr. Dawes, who can talk about best practices from a medical perspective. Doctor?
Okay, so as we've discussed, a lot of the focus is on diagnosis of COVID-19. And by statute, they always want the onset of symptoms to be within 14 days of working or the last exposure. And the reason for that is the incubation period of the virus, which typically presents, meaning you feel sick after about 5 days, and usually about 12 days is the maximum time after the exposure that you would develop symptoms. Of course, that's not a hard and fixed number. The virus doesn't know, how many weeks it's been. but it still takes but in general, within 14 days, you should see most of the people get sick if they've been exposed. And then the key issue is someone who has symptoms consistent with COVID. That means loss of smell, cough, not always a fever. And then, as we talked about, a positive test. And a positive test is a polymerase chain reaction test, which detects the actual RNA in someone who is symptomatic. And the key issue is that there are screening tests out there that we use that are not polymerase chain reaction, and they can detect and they can have a false positive, a much higher false positive rate. And therefore, you have to understand that this does not equal a COVID-19 claim unless there is confirmation with polymerase chain reaction assay. So that's really what determines a COVID case is PCR, not any other test, with the most recent presumptions. You know, and in terms of looking at this from a claim standpoint, what can we kind of expect when an individual is infected with COVID? Typically, the average person is going to remain at home during the quarantine period. They may or may not have some symptoms, and then they should recover fully. Some of the younger kids I've noticed seem to kind of have the loss of taste or smell persist a little bit longer, but that's not really something that's going to keep people away from work. Then there are the other individuals that do have a little bit of a persistent cough, maybe some weakness, maybe more fatigue, but in general, they should still be, you know, able to come back to work at least in a partial capacity. Then, you know, the more serious situations are those that are admitted to the hospital. And then those are admitted to the hospital that should develop a full recovery. They likely don't require oxygen, but they're still sick enough that they need to be monitored. And those that are inpatient that admitted into the intensive care unit, not only do they need oxygen, they may need life support like intubation to keep going. And so those are the people that are most likely to remain symptomatic. And we have a, you know, there's something called acute respiratory distress syndrome, which is very similar to COVID-19 in terms of the repercussions, meaning it's called, the acronym is ARDS. And it's a lot of tissue damage and tissue inflammation that limits a person's ability to breathe well. And COVID has a very similar clinical presentation, meaning damaging the lung cells in the same way. And so the big issue, those people that have similar lung damage will have some problems and likely require oxygen. And those are the ones that we need to be concerned about. So the two biggies are lung problems and heart problems. And, you know, a lot of people have developed what we call emboli or deep vein thromboses, and then they require long-term anticoagulation. So I think with a little bit more experience that I've had with the COVID cases since originally the broadcast started, I think those are the three things that we need to expect. Anticoagulation due to pulmonary embolus and a deep vein thrombosis for long-term. If an individual becomes oxygen dependent, that's going to be more long-term. And sometimes there may be some heart issues. And of course, these individuals that are typically inpatient have a lot of comorbidities and presenting factor and contributing factors to their illness. I'm sorry, go ahead. Next slide, please. And so, as we talked about before, treatment is still limited. It's supportive care. The corticosteroids are the like Depomedrol are the drugs that prevent damage to the lungs from the body, basically trying to attack the cells that contain the virus. We have some antiviral medications, and it just seems to me that the studies seem to fluctuate in terms of how effective they are. But in general, I think if someone's admitted to the hospital, it's a good idea to be on one of the antiviral medications, since there doesn't seem to be too much harm. From an outpatient basis, it's usually supportive care for symptoms. And the key issue is that they are isolated or quarantined until they're symptom-free, which is usually that 2-week period when they're presumed to be no longer infectious. And that's kind of what we use in the healthcare sector, is 2 weeks. And sometimes 10 days now with CDC guidance. So from a return to work perspective, after the quarantine period, the idea is that we want to avoid the spread of infection in other workers. And we also want to maintain mitigating measures in the workplace, which basically are the physical distancing, keeping people apart, wearing the masks at all times. And I can't reiterate this more. The most important thing that we can do to prevent the spread of COVID is in indoor spaces, wear masks. To me, that's the gold standard for compared to anything else. What can we do to predict delayed recovery? I think some of the laboratory tests that we have in the inpatient show individuals that have the deep vein thrombosis, and some of the chemicals, the chemical labs or kidney damage or heart damage will tell us that these people may have residuals in the future. But going back to what I'd spoken to before, that COVID is similar to other work-related problems, individuals also bring, anxiety and coping skills. And so there are tests out there that you can ask them, do you see yourself being able to go back to work, within 6 months, et cetera. And if they say no, and they're doing fairly well and they haven't had a severe course of illness, that is kind of a red flag and probably merits some type of intervention, such as nurse case management, or possible the primary care physician refer them for cognitive behavioral therapy to improve their approach to coping with the illness and maybe reduce some of their anxiety. And a lot of people have anxiety about COVID, even if they don't have it. So the key issue in terms of looking at residual impairment from a COVID illness is we need to establish a baseline. And how do we establish a baseline for individuals? And that's medical records. Have they had any tests, pulmonary function tests, EKG, treadmill tests, etc., that kind of establish what was that patient's cardiac function or heart function prior to the illness? And when we get, our final impairment, can we compare those two? Because that's going to be a basis for apportionment. And I can't emphasize the importance enough of getting those old medical records if possible. And the AMA guides are going to serve as your basis for impairment in 5th edition in California. And as I stated, I think the two big ones are going to be pulmonary, and pulmonary testing is basically pulmonary function tests, looking and also possibly obtaining what they call a DLCO or oxygen diffusion testing to see if there's any damage to the lungs. And if they've had something like that before, it should be a little bit easier to apportion back. And with heart function, if they've had an EKG or a treadmill test, we can get something to establish a baseline. And these ones, you can't, and these are fairly objective tests, more so than what we're used to in others. And of course, there's going to be pain and, fatigue and possibly some psychiatric comorbidities, which will need to be addressed and assessed as well. But I haven't seen the proliferation of significant issues outside of the heart and the lungs so far, thankfully. Next slide, please.
All right, so now we're going to get into best practices for the investigation. I think the first point that we want to make is that this is going to be a living document. I mean, by no means is this just a one and done list of questions and that's it. I would encourage everybody to make a list and add to it. Particularly what I know Tim and I do is if we get a unique answer from a question, which is, where have you been in the week before you tested positive? I add that specific thing to my list. As an example of that, I asked somebody, where have you been in the prior week? And they said, well, they delivered some recyclables to a local recycle. Well, now I'm asking everybody I interview and depose about, have you been to a recycle center? So the point being, make it a living document. I mean, the first question has to be why. Please always ask the employee, first of all, do you believe that you contracted COVID-19 from the work environment? And then if they, you'll be surprised. I'm getting a lot of answers, I don't know. And I know a lot of my clients are getting answers such as, no, I don't think so. And then of course there are some that say, yes, I do. And then follow it up with, why do you believe that? And the valuable information you can get from that is just, we can't stress it enough. I had one case where somebody said, well, there's people coming into the store and they're not abiding by the you sign on the door requiring that you wear a mask when you come in. or half the time people coming through my register don't have it covering their nose. So the more you can get from the employee on why they believe they contracted at work, the better, because that's just going to help your investigation. Because that information is going to have me go find out if there's store surveillance. Can I prove or disprove, the statement that I just got? And of course, whatever other information I can find out. But we could never list all of the questions for an investigation on our slides. This would be a 100-page slide. But you get the idea for this. Is like, when were you tested? Who performed the test? When was it? When were you tested? When did you get the results? Did you have a prior diagnosis? Specificity on the symptoms is key. Ask them very detailed questions. Exactly what symptoms did you have and for how long? And ask that of anybody in the household as well. And if they've been quarantined, ask who ordered them quarantined and when.
And as Joanne indicated, obviously the list is not exhaustive. We've been adding to it for almost coming up on a year now. And what was not necessarily common knowledge, back in March of 2020 is common knowledge now. So obviously we want to ask questions about travel, especially in light of the fact that what's going on with travel, whether it's international, domestic, depending on what state you're going to, depending on what state you're coming from, changes all the time, what those particular requirements are. We want to talk about shopping, grocery shopping. If you want to talk about going to Nordstrom's, we can do that too. However, I'm really focusing on grocery shopping because most of us need to eat food. How often do you go? Who does it? Is there a protocol within the particular store as far as individuals wearing masks? I remember we're seeing a large number of COVID claims from grocery checkers. So we want to talk about large gatherings. Obviously, we saw a lot of that coming off the holiday season. It doesn't necessarily have to be the holiday season to have large gatherings, but we would definitely want to find out if the individual's been part of that recently. Exercising, again, it depends on what day it is as to whether or not a gym is open or not open. For example, I know my gym is open, however, it's set up in the parking lot, so it's outside. Are you going to the gym? Where's the gym? Is it outside? Are people masking up? Schools and child care facilities, we definitely want to talk about that. Obviously, some children are going to school and some children are at home and remote learning. So who are they being exposed to? Who are they not being exposed to? If we're back to work in an office environment, we would definitely want to be talking about what the protocols are in the office. What are the PPE protocols? Are they being enforced? If you're in a commercial building, what are the protocols for the individuals that are cleaning the building? Are there enhanced protocols? I know most of the offices that I've seen have enhanced protocols. The management of the building has been coming in and doing additional sanitation. Is the employer doing any additional sanitation? What's the social distancing in the office? Definitely things that we're going to want to ask within that very short time frame to help us come to the conclusion as to whether or not this is potentially work-related or not.
Yeah, so the next two things, look, the level of the quarantine they've been following outside of work, rather than go in with very specific questions to the employee right off the bat, I want to know what they're going to be reporting, okay? Because again, if I'm trying to determine if I can controvert these presumptions, I need to know what I'm trying to controvert first, right? So I'm going to say, what level of quarantine have you been following outside of work? And they can tell me, right? And then I can go in with my questions. Well, I mean, have you driven anywhere? Did you have to go to the gas station? Do you have somebody filling up the gas for you? Because if they say I only go from my home to my work site and back, well, at some point you're going to run out of gas. Do you go to the gas station, but they just told me they only go from point A to point B? Well, I just controverted something, right? I'm not maybe getting the complete story, or maybe they're just not thinking in their mind, oh yeah, I do go there too. So again, it's about controverting the information that you're getting. That's really what we're after here. Same with mask wearing behaviors. Do you always wear a mask when you're outside of your house? Oh yes, always I do. That's the answer. Now I can start chipping away.
Hallelujah.
When you get out of your car and fill up your gas tank, do you put on a mask even if nobody else is there? Well, no, not then, because nobody's there. Okay, well, I just controverted the statement that I always wear it. So if you just follow sort of that as a guideline for your investigation questions, it's really going to help us controvert the presumption if there's, you know, sufficient information to controvert it. Of course, you can ask a lot of questions about the shift information at work. You know, again, there's a million questions. We're just keeping a living document. And again, I'm adding to it, Tim's adding to it, whatever you find out. And the social media canvas, look, you can find out a lot on social media, you know, if they're saying they're not going anywhere, but from, you know, my house to the work site, and now I just said and added in gas station, but now there's a picture, you know, outside, you know, restaurant in the parking lot of a hamburger joint. I just controverted that, you know, so that's what this is about. The other thing is about contact tracing, finding out, you know, who they've been around that had symptoms but didn't test positive, had no symptoms, or who did test positive.
Yeah, and you can even ask the individual, if you've had contact tracing, did any individual tell you where they thought you might have potentially gotten it from? So,
Ooh, that's a good one.
Questions. Yeah. We're going to ask about if anybody in the household's been diagnosed with COVID-19. Obviously, who was it? When were they diagnosed? And we want to compare that answer to applicant's allegations of the onset of symptoms and diagnosis. You know, was applicant's diagnosis or presentation of symptoms after the family member was diagnosed with COVID-19?
Yeah, and also, you know, normally we're taking statements of coworkers. So we definitely want to continue to follow that protocol for the COVID claims. Ask the worker about their, you know, if they have any friends that have, you know, tested positive, that they've been around, etc. You know, you kind of have to just be willing to follow the train of thought of the answers that you get back in your investigation. And honestly, that leads to a very unique investigation, case by case. And I think in our experience, Tim would probably agree, is that that's going to get you the best information for controverting a possible presumption case by case basis.
Absolutely.
Right, Tim? Yeah.
Absolutely.
And then, of course, you know, if there's any kind of, you know, store cameras, keep in mind that could not be positive for us, but if there's evidence showing that in the location of the employment that people came in without masks on, you know, that's still evidence that possibly could support the claim. So we're doing fair claims handling here. We are wanting to do the right thing for the employees, and if it is work related, we're not trying to deny those claims. So just keep that in mind. All right, so we put this website up here if you want to, and we highly encourage you to try to find known clusters of, you know, COVID positive testing, and you can go to this website and look for known outbreaks in the area. And there's lots of places to find this information too. And we encourage you to do that because, again, it's just another piece of the puzzle. It's never going to be one or two things that controverts a presumption, right, Tim? It's going to be like a number of things, and the big picture is potential controverting it, right?
Right. I mean, those are the odds. The smoking gun is rarely found in the investigation. It's usually everything added up together. So, and you know, as Dr. Dawes indicated, we definitely want to get in there and establish a medical baseline. Okay. We want to talk about any respiratory problems that the individual might have had in the past, pneumonia, any pre-existing conditions like COPD, cystic fibrosis, asthma, smoking. Do you smoke? Have you ever smoked? What have you smoked? We are in California. Have you vaped? We definitely want to get in there and get those medical records. Run-of-the-mill claims, we might not have a lot of stuff. testing in those medical records, prior testing in those medical records that we can use. Those of us that handle safety officer and firefighter claims, you know, there might be 1 or 2 or maybe 10 or 15 prior claims. You might find an echo in there, an echocardiogram. That would not be unusual. So we might have some good diagnostic baselines that we have in the medical records, you know, prior to the filing of the claim. Please remember that the investigation time commences after the claim form itself has been filed. Okay, just like a regular old comp claim, but again, we're looking at 30 or 45 days as opposed to that 90 if it falls within the presumption. If it doesn't fall within the presumption, it's 90. Remember that. We want to focus on contact tracing for sure through claims investigation and medical record retrieval. Again, surveillance, video footage around the time of the alleged exposure that might refute from a factual perspective that the individual was following appropriate PPE protocols. And we definitely want to focus the investigation if necessary on defending any attempt to qualify the illness as catastrophic that could potentially allow applicant to claim psych injury, PD for psych under the Wilson case. So that's always lurking around the corner, remember.
Okay, so before we get into best practices for med legal evaluations, I want to ask Dr. Doss, what is your perspective? Tell us, what else can we try to find out during our very short investigation period medically that would help us determine if this was an industrial exposure and or to controvert the presumptions?
Well, I think you've covered everything really well with your dialogue and list of questions. But to me, the big red flags are if someone believes that they contracted it at work and everyone's wearing a mask indoors and no one's actively sick, that to me would be a red flag. And if they're outside and wearing a mask, or, you know, even unmasked and outside and not in a, you know, population dense area, that would also be a red flag. Those are the two things that I think would kind of push me to want to investigate a little bit more, rather than if someone says routinely that individuals are unmasked indoors at work, I wouldn't be as curious.
Okay, oh, that helps. Okay, thank you. All right, let's move into best practices for med legal evaluations. This is obviously key points here on how are we going to be addressing these cases with our QME doctors. The best thing we can do is get the records. Okay, look, Dr. Doss just literally gave us gold information about oxygen levels. Ask if the person has had prior treadmill testing, EKGs, asthma, inhalers. I mean, come on, all of that is going to go toward whether or not any resulting impairment was the result of a natural progression of a pre-existing condition, and that's all going to go toward apportionment. Apportionment absolutely applies to these COVID cases, and we need to go after it. You know, we have to find out. We want to make sure that our employers are not, you know, having to take on a liability of a natural progression of a pre-existing condition. So that's our job, you know. And any medical report, of course, has to constitute substantial evidence. That means, you know, be cognizant. If the doctor is basing any part of their opinion on conjecture, surmise, guess, if it's not supported by how and why they came to that conclusion, if they don't say reasonable medical probability and tell you why they're coming to that conclusion, or support it with any kind of medical studies or based upon the records that we have in the case, then maybe that's not substantial evidence. And that's a big part of our jobs, right, Tim, is to go after the evidence and make sure it's substantial, whatever it is, right?
Correct.
Yeah. All right. So again, best practices for benefits now. We've talked about this. Just make sure that the employee exhausts the COVID-19 specific benefits before paying TD. Document your file that you're sending benefit notices, same as regular cases, but you have to establish a basis for a delay in TD and focus on the pre-existing conditions for your discovery and on those questions, getting the information from the employee before you go into your specifics so you can help controvert, and see if you can establish that there's no rateable impairment, which I think Dr. Dawes is telling us the vast majority of people are going to come out of this with no rateable impairment under the AMA guides. Right, doctor?
I believe so. Yes.
Yeah, great. Of course, we have to, Tim, right? We have to always keep our eye on Almers Guzman and see if a clever applicant, attorney, or doctor is going to try to analgize whatever residual condition there is to get some impairment, even though traditional strict application of the AMA guides might not give them any impairment. So we just have to be defending that. Again, how and why, and is the opinion substantial?
Yeah, and I think the fact that you're discussing that the opinion is substantial is very important, because I would say in my experience, and your experience with Joanne, because we've never really discussed this, but the vast majority of cases that findings that I disagree with, and when I mean findings, I mean from the WCAB, that we appeal, are based upon findings where the court simply says, well, the doctor said X, Y, Z, and our response is always, yeah, but how did he get to X, Y, Z? How he got to X, Y, Z is a joke. You're just looking at the last paragraph, you're not looking at the analysis, and that's something that we really need to take a look at, which again brings us back to having to emphasize getting that discovery done and getting those medical records, and hopefully medical records that exist prior to the allegations of COVID. So, doctor, at the risk of asking you to repeat yourself again, I'm going to ask the $64,000 question, which is, what items can we look at as defense attorneys, as claims administrators and professionals, as employers, as carriers, at the onset of a claim to say, hey, you know what, this might be a claim that we want to get out of quickly. This could turn badly for us. Some type of predictor that lets us know that, yes, the claim was filed, but this is something that we need to really watch, and if possible, get settled and get away from this as fast as possible.
I think we did hit the highlights earlier in the talk when we talked about oxygen dependence. So that is something that's probably not going to change, and it probably means that there's going to be a lot of there's going to be long-term care, and the likelihood of full recovery after that is probably less so. They analogize it to acute respiratory distress syndrome, and so a lot of those people 5 to 6 months out until they have a full recovery. So those are the cases that I think that we have to be concerned about, where they have significant lung damage, lots of medications afterwards. Having a pulmonary embolus or a deep vein thrombosis definitely means that they'll be monitoring for medications, etc. Those are the ones that require good case management and thinking about what the long-term residual is going to be, because this is, in workers' compensation, it's a little bit different than in, typical health plan types of cases. So those are the big ones, I think. And the hospitalization, intensive care unit, and lots of meds, and looking, if you have baseline references, looking at damage based on pulmonary function tests to the lungs.
Excellent.
Nice.
Okay.
All right, well, we're not going to go through the flow charts, but we did put together these flow charts for ease of going through the applicability of these presumption statutes, and also for consistency in your claims decisions. So take a look at those after and let us know if you have any questions on that.
Well, thank you also very much for your expertise. There were a couple times we talked about records. So before we ask the questions, I do want to talk a little bit about records and the record retrieval process. Currently, things have slowed down with COVID. The numbers have come up as far as the infections in California. One person dies every 6 minutes in LA County. So obviously this has affected how quickly we're able to deliver those records to you. Many custodians are not open, they're just shut down. Others are sophisticated, they're able to provide the document retrieval companies with records electronically. However, those companies that are not as sophisticated and unable to provide the records, let's say that they're provided by paper, for example, it takes longer. And because of social distancing, number of employees that are available to work, those that are out because of COVID, there's a reduced staff number. So we're getting those records much slower than we have in the past. So to help mitigate that and to get your records quicker, there's a few things you can do. First of all, place your orders online. I don't care what company you utilize. Hopefully it's MacroPro, but order your records online because that's going to expedite it. Make sure that you provide all attachments and authorization forms, extra subpoena messages if you have something special that you want, any type of attachments. Put them all on one order so that they don't have to go fishing for them and they can get your order in place and outgoing. And then skip paper and skip the CD. Ask for a download. Or better yet, see if your company like MacroPro can actually drop them right into your file, and that'll expedite it for you. All right, so having said that, we have some questions, Doctor. Maybe we could do a little rapid fire for you, and then we have a question for our attorneys as well. So first of all, how long is COVID contagious?
In terms of within that 14-day period, typically that's when people are going to be contagious. So when someone has an active illness, I'm not sure if I understand the question correctly, but when someone is within that 14 days and in fact and is producing virus, yeah, they're infectious. So I don't believe that if after people are symptomatic and have recovered that they're infectious, if that's the question, because some people test positive for the RNA, and that's thought to be residual RNA fragments as opposed to active virus. So typically we would be within that 14-day infectious period. I would consider someone to be infectious. Before that, a little bit before that, and at the time they became asymptomatic after the 14 days. In general, I think that would be the biggest hunk of the bell curve. I hope that answers the question.
Okay, if an employee is on an anticoagulant at the time of contracting COVID, will that help them and keep them from being intubated?
Well, the intubation's typically because that they're not getting enough oxygen and their lungs aren't they're not able to breathe well. So the intubation's a little bit independent of the anticoagulation. What the anticoagulation will do is prevent a deep vein thrombosis, which will prevent a pulmonary embolus, which may prevent them from getting intubated because their oxygen drops a lot. So from that perspective, yes, but it won't stop the ravages of the COVID illness if it damages the lungs a lot. So the answer to that is yes, since it will likely prevent a deep vein thrombosis, and no, because it won't impact the significance or the severity of the COVID disease.
All right, is it necessary for a person that is working in a private office to wear a mask, especially if they keep the door open to the rest of the staff?
My personal bias is that I'd rather make the mistake of being too careful. And so with these new variants that are out there that are supposedly a little bit more contagious, especially if you're an employer, I would strongly encourage everyone to wear a mask indoors when there's an opening in a space. So if you're in a private office and no one's going to come in to say hello, yeah, maybe you could probably not do that. But in general, there's always someone walking through. So I kind of recommend wearing the mask because then you kind of forget about it. And then there's a potential exposure there. And even if it's not something that's a meaningful exposure, it still can be represented as such. And so I would prefer that people just avoid the discussion about whether they could have gotten it there. Good.
So part B of the question was if colleagues are 6 feet apart from each other and they're working, can they not wear their masks? But I'm going with they should be wearing them based off of your last question.
Yeah, the virus, I don't know. I'm not aware that the virus is aware of the 6-foot rule. So until we can educate the virus about how far it can travel, I think we need to be a little bit more careful.
All right.
And there have been instances of people contracting virus beyond 6 feet. There are studies showing that with ventilation, et cetera. So the 6 foot is not a hard and fast thing by any means.
When should employees be told of a coworker that has been exposed to COVID-19 or tested positive? If the employees are sometimes in the office and sometimes not?
Well, I think you kind of answered the question. So I think it's a need to know or a case by case basis. So if someone's not in the office, kind of like, you were given a great kind of way to kind of look at the cluster in terms of the timing and the sequencing of employees. And I think if you follow what Tim and Joanne developed, I think that would be a good way in terms of developing, it's because it also falls back to contact tracing. So if someone was in there at the same time, that would be useful from a contact tracing standpoint. And if they weren't in the office during that time, I don't see the need. That's my personal opinion, though, not representing anybody else.
All right, Tim and Joanne, I have a question for you. Does the 90-day decision date apply if a signed DWC-1 form has not been received? Or does the 30-day, 45-day decision date apply regardless of a form being signed?
Good question. Go ahead, Tim.
It is a good question because Joanne, I've had this question yet. So I'll do part A, and I know what your part B is, Joanne. Okay. I will say generally most of the time, 90% of the time, with an exception that Joanne will discuss, the no time frame starts, 30, 45, or 90-day time frame starts until the claim form is filed. It's been that way with regular workers' compensation cases. It is that way with COVID. The COVID cases, the statute expressly refers to the filing of a claim form under Labor Code Section 5401, which is the exact same section that we use when it pertains to, a trip and falls or whatever other industrial injuries are being alleged. There's a lot of play in that, but the long story short is pretty much unless the employer is willfully not giving that claim form or is fully aware of the fact that the COVID is industrially related, then and not giving that claim form, then the 90 days, the 30 days of 45 does not start until the claim form is completed and filed under 5401. Joanne.
Yeah, so I just want to say that if your employee has indicated that or the family has indicated they believe that they contracted COVID-19 from the work environment and they're in the hospital, i.e. they can't complete a claim form, and you have knowledge, as I'm saying, from any source, the employer or the family, they're claiming it work-related, I think you got to consider that the filing of a claim form for your decision date at that point. I just think that's the right thing to do.
Yeah, riffing off of what the doctor was talking about, I think as employers, it'd be difficult to say, well, we never got a signed claim form back. Well, 20 people told you that it was industrial related and applicants lying in ICU intubated.
Got it.
Oh,
exactly.
I don't want to be in that position.
Right. But that's different. That's different, though. Let's just make sure we say if they're not in the hospital and they're home and you send them the claim form and they didn't file it, then what Tim said applies. Absolutely.
I have another question for our attorneys here. Are TT benefits notices due if an employee is receiving COVID payments and does not qualify for TTD? If so, which ones?
That's interesting. I'm not sure I understand the question. And the reason is, well, the reason is because we have COVID specific 19 benefits that get paid, that could be paid under union agreement. They need to be paid regardless. So to the extent that those benefits, in my opinion, to the extent that those benefits are being paid outside of workers' compensation, we don't issue any TD notices. because it's not being paid pursuant to the labor code. There's no liability to pay those benefits under the labor code. It's per statute or per union agreement or per the agreement with the employer. That's kind of how I interpret that that question.
All right, I have one last question for both Dr. and for our attorneys. The first one is, Doctor, can you tell us how effective these COVID-19 vaccinations are? And of course, will they be helpful in the workers' comp community?
Well, I think that the studies that we have show that after the first dose, that it's probably 50% effective against people getting COVID illness. So it's not just a matter of developing neutralizing antibodies, but it actually prevents illness. And it's over 90% after the second dose. So I think that with the strain of COVID that was tested, the vaccine is very effective. And my own personal opinion is that, my own personal opinion is just that even with the variants that are a little bit more infectious or a little bit more contagious, I'm kind of hoping that it means that the spike proteins on those viruses are a little bit more exposed and maybe more susceptible to the neutralizing antibodies than the less contagious COVID that they've been tested against. And that's kind of what I'm hoping for. So I'm more positive than I ever was about the vaccine, because there were some questions about how effective our own natural immunity was against the COVID antibodies. But it appears that the vaccine-induced neutralizing antibodies are very effective. And I wasn't sure if I understood the workers' comp context.
Well, I think they were just wrapping it into the question based on our industry.
Okay.
A question came up whether or not, Tim and Joanne, if an employer requires a vaccine in order to come to work, if there are any type of complications in the future, say thick blood or something else that might come up that might be affecting the employee, is the employer going to be liable for that?
So you had me at employers requires. Joanne?
Yes, we're worried about that. Of course, we're absolutely worried about that. And unless and until there's some statute or some governmental, order saying that the employer will not be liable for those, just keep in mind the entire last hour. Best practices. Be careful.
Yes,
be careful.
absolutely. Well, the airlines are requiring that for international flights, so it's be interesting to see what happens with that. All right, well, Melissa, if you want to come join us, I want to thank all of you for joining us today, and thank you for your expertise. Doctor, I know you're in New York today, so thank you so much for joining us. Everyone, if you have any questions, feel free to reach out to SRTK directly. Doctor can answer questions through them. We've got everybody's emails listed here for you. The handouts are attached to this webinar, so I'll leave it up for a few minutes before shutting it down. All right, everybody, goodbye, and we'll see you at the next edition of MacroPro and Friends, which will be coming up. Please check the MacroPro website at macropro.com. There will be a whole listing of all of our webinars that are coming up in the next 2 months, and I think there are about 6 of them listed currently. All right, until then, bye-bye.
Bye.
Stay safe.
Bye, everybody.
Thank
Stay
you.
safe.
Thank you.
Hey, can we work out a wrap up with everyone real quick with Diane and Tim and Dr. Dawes? How do we do that?
Yeah, we're still online, so we still have some people attending that may be downloading our handouts. So I'll close down the webinar in just a few minutes, and then we can do it by phone.
Oh, sounds good.
All right.
Okay. Thank you.